Good afternoon, everyone. Thank you, Balamurugan sir, for giving me this opportunity. Thank you to my dear teacher, Anuradha ma'am, for always mentoring and guiding me. So my topic for today is anterior uveitis and avoiding very common management errors. It will mostly be a image-based discussion. So why is anterior uveitis so important? So 90% of all uveitis in general ophthalmology clinics, it comprises of 90%. Any inadequate diagnosis and treatment of anterior uveitis can have severe visual implications and systemic complications. And pan uveitis can start as anterior uveitis. So coming to the definition, according to the Sun Working Group, the anterior uveitis, the primary site of inflammation is the anterior chamber. We have to remember there is no vitreous inflammation and no focal lesions in the posterior segment. It is inclusive of the terms iritis, iridocyclitis, and anterior cyclitis as well. So where all can we go wrong? We can make mistakes in the diagnosis, we can make mistakes in the management, and complications can arise due to management. So a simplified approach to anterior uveitis. So first and foremost, we have to confirm anterior uveitis by adequate and proper slit lamp examination. Do not diagnose any case without thorough fundus evaluation. Second is, as Balamurugan sir was saying, we have to take time and assess the type of keratic precipitates. Look for non-granulomatous or granulomatous keratic precipitates. Look for iris nodules. Look for peripheral anterior synechiae, posterior synechiae, and pigments. So is it only anterior uveitis? So our main purpose is to identify what is the primary focus of inflammation with a thorough and complete fundus evaluation. We have to find out whether it is any vitritis which is spilling over to the anterior segment, or is it any posterior uveitis which is coming to the anterior segment. So this was a young boy who presented with coalesced granulomatous keratic precipitates and anterior segment inflammation. Had we not dilated and seen the fundus, we would have missed this very obvious headlight and fog appearance of typical toxoplasma retinochoroiditis. This is a second example where you have the stromal haze, you have iris nodules, a festooned pupil, and complicated cataract. If we didn't take time in imaging and seeing the posterior segment, we would have missed the solitary choroidal tubercle, and this was a case of ocular tuberculosis. So the next point is, if we see this patient, yes, we have obvious signs of anterior uveitis. But the most important thing is we have to retract the lid and we have to look for some very obvious clues that can help us to diagnose and treat the patient. So in this case, we can see the very small trace hypopyon on retracting the lower lid. So retract the lid and examine thoroughly. Hidden clues to diagnosis like this hypopyon, trace hypopyon can be seen in HLA-B27 or Behçet's. Even in a white-eyed eye presentation, look for very obvious clues. Even if the eye is white, doesn't mean that there cannot be any other signs of inflammation. Look for clues that can help you in your diagnosis. So now, if the keratic precipitates are granulomatous, you have your typical mutton fat, greasy appearance. They are very voluminous keratic precipitates. They are not flat endothelial dusting. It helps you to narrow down the causes and helps in a very targeted treatment. So all granulomatous anterior uveitis can start and end as non-granulomatous. When they present to you, they might be treated in multiple clinics with topical steroids, and they might be presenting to you with non-granulomatous pigmented keratic precipitates. You have to keep this in mind. So the first category of granulomatous anterior uveitis, is it tuberculous, where you can have the typical tuberculoid granuloma described by Ratnam madam? Or is it sarcoid, or is it lepromatous with all the peripheral anterior synechiae? So it is not just the anterior segment findings alone. It is, our diagnosis is complete only by examining the patient with a complete physical examination. You can see the obvious clinical features in leprosy. It can be a positive manto or even supported by our radiological features. Granulomatous anterior uveitis not only infectious, it can also occur as a part of panuveitis, the Vogt-Koyanagi-Harada or the sympathetic ophthalmia. So you have the typical keratic precipitates of VKH, the sunset glow and retro illumination. All these findings can be picked up. Again, supplementing this, you have to do your posterior segment examination, rule out whether it is in the active phase, chronic phase where you have your sunset glow, Look for the CR scars in the periphery, very typical of sarcoid. Look for vitiligo patches, poliosis, all a part of VKH. The third category is viral anterior uveitis. It can be herpes simplex, varicella zoster, or even cytomegalovirus. The two P's that you have to remember in viral anterior uveitis is pigments and pressure. So look for pigment dispersion, look for iris atrophic patches, pigmented keratic precipitates, and a raised intraocular pressure. So you have your heel scarred corneal keratitis or the iris atrophic patches and the characteristic D-shaped pupil of viral anterior uveitis. Supplementing this, we have to go with all the systemic features of this is herpes zoster, as you all know. In viral uveitis, it is very, very essential not only just to see the posterior pole, you also have to see the periphery, or you could be missing something as fulminant as acute retinal necrosis. So this is an early and late stage of acute retinal necrosis, which would be missed if we don't see the periphery in such cases. The fourth category is your Fuchs uveitis, which is a diffuse stellate granuloma. It can even be granulomatous keratic precipitates. There is no posterior synechia. It is one of the differentials of white-eyed uveitis. So the other differentials would be juvenile idiopathic arthritis, Behçet's with hypopyon, a mobile hypopyon, and even Masquerades. So now coming to non-granulomatous, the non-granulomatous category. So this is the image with a very severe circumciliary congestion, dense fibrinous reaction in the AC. Ask for history of inflammatory joint pain, back pain. There is something called as a ping pong presentation, which means it alternates between the two eyes and presents with fibrin membrane and hypopyon. Along with systemic features like this, test for HLA-B27 and rule out ankylosing spondylitis. So this is a young child. So you can see the band-shaped keratopathy, complicated cataract. So this is a complication of anterior uveitis if not treated properly. So in the pediatric age group, think about juvenile idiopathic arthritis. Now, this is a case 8 months ago. He had a history of trauma, multiple places. He was treated as anterior uveitis with multiple doses of Predford. Finally, when he came to us and we elicited the history of trauma, and on slit lamp examination, we saw the penetrating injury in the temporal aspect of the cornea. It was like a through and through wound. And on UBM, we had a foreign body. So this was a case of siderosis bulbi. So it is a case which closely mimics chronic anterior uveitis. And so you have to keep this also in mind. Then do not get misled by the pigments in pigmentary and pseudo exfoliation glaucoma. Then, is it really uveitis? It can be drug-induced as a part of rifabutin, cidofovir, bisphosphonates, sulfonamides. Is it a masquerade where you have a white-eyed uveitis, large cells, aggregates with a lumpy, bumpy hypopyon, and it will have inadequate response to steroids? Also, rule out other causes of red eyes when you have a case of anterior uveitis. It can be scleritis, it can be keratitis, it can be conjunctivitis also. In a case of masquerade, again, dilate, see the posterior segment and the periphery, or you're going to miss something as aggressive as a primary intraocular lymphoma, or it can be secondaries with exudates and subretinal fluid. Now coming to the diagnosis part is over. Now coming to the management mistakes. So as mentioned before, dilate, dilate, dilate. Anterior uveitis does not preclude other pathologies. If you cannot see enough of the posterior segment, do not hesitate to get an ultrasound or OCT. A fundus photo montage through a small pupil can also help you to reveal peripheral pathology in case of a small pupil. Treat aggressively. When treating a patient with severe inflammation, hit hard with topical steroids and taper slowly over weeks. Abrupt weaning of topical steroids is a trigger for reactivation of uveitis. So always remember to taper slowly over many weeks. Don't hesitate to add any cycloplegics. It is mainly for pain control and to prevent posterior synechia formation. But they only work if in cases of acute anterior uveitis. So no need to keep patients on long-term cycloplegics. Do not let the inflammation worsen just to keep the IOP under control. And when you're using cycloplegics, remember to avoid using cyclopentolate as a cycloplegic because of its pro-inflammatory action. It's actually a neutrophil chemotactic and breaks down the blood aqueous barriers. So remember to avoid using CPENT as a cycloplegic. Remember, there is no standard workup for all uveitis patients. So when you order a diagnostic test, as Eliza ma'am was mentioning earlier, make sure the results affect your management. The test should help you to rule in or rule out a disease. And in our population, TB is a very ubiquitous disease. It can coexist with everything. So rule out infections before commencing steroids. Do not treat only on the basis of blood or ocular investigations alone. For example, a positive Manto is not an indication to start ATT in all patients. Treat on the basis of clinical impressions supplemented by other blood tests. Avoid using only topical therapy when you have posterior segment manifestations. You will have to initiate oral steroids after ruling out infections. An important thing in JIA uveitis is do not undertreat the anterior segment disease in children. You have to be very aggressive in treating them. You have to treat the inflammation irrespective of the visual acuity to avoid any long-term deleterious effects. As I showed the picture earlier, you can end up with a band-shaped keratopathy, complicated cataract, and other visual implications. The comorbidity management. Glaucoma is a part of uveitis. It is present in about 10% of all uveitis patients. Remember, the only mechanism is not a steroid response. So always check the angles for peripheral anterior synechiae. Trabeculitis can also be a reason for the intraocular pressure rise in cases of viral anterior uveitis. So look for the cause of secondary glaucoma in uveitis patients. So to summarize, in anterior uveitis, examine completely with a thorough slit lamp. Do not forget a fundus and periphery examination. Use imaging when required to see the unseen portion of the eye. Test specifically for infections before you initiate any systemic therapy. Treat aggressively based on the inflammation and not just on visual acuity, even if you have a 6x6 vision, to avoid any complications. Chronic recurrent anterior uveitis require long-term immunosuppression for any optimal outcomes. Thank you.